So the first topic today we are going to do is from the pediatrics is routine immunization. So here this routine immunization of Ontario is written. So we have to remember the immunization of the whole Canada. Roughly it's quite the same. Only few differences here and there about TDAP and those things. So you need to make sure that what you are studying is basically applied to whole Canada, not just one province. Even in the even when you are doing that particular, I'm sorry if you guys can mute yourself, it would be really nice. So next comes is basically, so here what we are going to talk about is basically Ontario. So I have sent one of the picture in WhatsApp group. It's basically thoroughly written about all the immunization. So what you need to remember in immunization. So basically it's when Tdap is given, when DDAP is given, when pneumococcal is given, when rotavirus is given, and when meningococcal. How many of these are repeatedly given? Like 1, 2, 3, 4, and how these doses are given. And when you are giving that, what are the counseling that you are going to give to the patient or the patient's, not patient, but the child's parents. So how you are going to counsel about that. So starting from that, 2 months. So sometimes they ask in the question, when is the first immunization started? So before 2 months, you'd hardly give any. Only on the time when hepatitis B is found out, then you give the immunization of hepatitis B. Otherwise, there is no immunization that started before 2 months. So you have to remember this, all these time period, and when are these given, which one is given per oral, which one is given IM, and which one is given subcutaneous. And the mostly important for the, because a lot of questions when a person is having a trauma or everything, so you have to remember this TDAP. It is hardly like it is applied in emergency as well, so you need to know. And this hepatitis B, HPV is applied in gynae, so you need to know when is this going to be started, and one is the first dose given and one is the second dose given. Okay. So then moving on to the next one, this adverse reaction. So it is important that you need to know what is the adverse reactions and what are the contraindications. The main important contraindication is basically of the rotavirus, which is basically immunocompromise and intussusception. It is not given, and in Meckel's diverticulum. So any children who is coming with intussusception or Meckel's diverticulum, even if he's suspicious of intussusception and you are not like sure that he has intussusception, still you are going to not give the rotavirus until it is ruled out that he has or has not intussusception. Then on the basis of that, you are going to give rotavirus. So otherwise, TDAP has contraindications, hypotonia. If somebody's baby is presenting with cerebral palsy, so obviously you are not going to give TDAP. Anaphylactic reaction to neomycin, you are not going to give that. Then MMR, pregnancy, immunocompromise, anaphylactic reaction, all of these. And what are those adverse effects, what they definitely cause? And the main important adverse effect is basically fever, those kind of things. So if somebody is presenting with a fever or mild viral infection, what are you going to do? You are going to let the patient settle down or treat the baby about that, or maybe leave it for 7 days until the viral infection resolves, and then you can give the immunization. But it is not applied in all of them. It is applied in few. Okay, so you need to know which one is where, and what are the adverse effects and what are the contraindications, because on the basis of that you are going to tell the mother or the father of the baby that this is like contraindicated in it. Like just like this egg allergy, what are you going to not give is basically influenza. In immunocompromise, all those live attenuated is not given. So you need to know what is live attenuated, which one is not live attenuated. So on the basis of that, you can decide which one is given to the immunocompromised person and which is not. And other than these immunization, what other immunization you need to remember? The age 65, after that you give pneumococcal, meningococcal. Those vaccinations are important as well. In the patient of COPD, what immunization you are given? Pneumococcal, meningococcal. So those immunizations are important as well. So before doing let's suppose any surgery, what immunizations you need to be checked on. Before going to the school, a mother is coming to you and she wants her, she is an immigrant, she's coming to you, her baby does never have any immunization, or she had immunization but she doesn't know. So how are you going to counsel it? What are you going to tell her? On the basis of that, you have to know what are the basic immunization that is required when a child is going to the school. So you can go to I think it's canada.ca or something like website, and every immunization according to the school, according to when you are going to travel, everything is written. You can go and there is a table very nicely presented So you can remember from there. Then moving on to the next one, these adverse effects following immunization must be reported to the local or regional. If it's very highly, so you have to tell the local and the regional health that this kind of immunization is causing this problem, so they can do further investigation about that. Has a temporary association with the vaccine and has no clear cause at the time of the reporting and meets one or more serious criteria. Then temperature is basically after for the vaccination is like +2, +8. Then modification of the routine vaccination schedule. If somebody is coming with the vaccination, let's suppose his baby is already vaccinated for 2 or 3 times and she doesn't have a vaccinated card, and now she wants you to make a vaccination card, but you are not sure that that baby is vaccinated or not. What are you going to do? You are going to ask for the catch-up vaccination, like all those vaccinations he or she missed. And if that particular person or that father of the baby asked you, if my baby is going to get overdose of immunization, so there is no such thing called overdose of immunization. She can get catch-up vaccination, like if he is coming at 2 years, so what are those immunization that is given at 2 years, you can give it right away, and the rest which is left, you can ask her to come back and we can catch up with that vaccination. So you can counsel it, but you cannot give the vaccination card unless you are sure that you have given the immunization or that particular baby has received the immunization. So it is very important. So update and then Ontario catch up vaccination. So it is basically written for the Ontario. Okay. Then immunization of the immunocompromised patient. This is what I was talking about. What are the immunization that you can give in the immunocompromised? All the live attenuated you cannot give. So all live attenuated avoid. Okay, so you cannot give. And then serology testing and reimmunization immune response may be inadequate, and post-immunization antibody titers, if appropriate, and positive serology test may be due to immunoglobulin therapy. Vaccine hesitant parents. Now somebody is coming and they want vaccination, but at the same time they have some problems. So what is the first question you will do? You will try to explore their reasons or what they thought about the vaccination before addressing. You need to know what they were, at which platform they are starting, like they are standing. So you can ask them, okay, what is your thoughts about it? What do you think about it? Sometime in CDM question, you have to write down, instead of choosing it, you have to write down. If they ask you if a vaccine hesitant parents is coming, what are you going to do? You have to ask the reasons from that particular patient, parents, that what they think about it, why do they think about it. So you have to explore and then address those concerns. So use open-ended question here. This is the listen to the parents concern and opinions. Do not consume the health and concerns, and sorry, assume, do not assume. And then address concerns non-judgmentally and non-confident confrontality. Like if they are telling you something, you don't have to be judgmental. Oh no, this is not like that. So you have to be well acceptable, and then answers should be answers should be appropriate enough, so it will help them to understand what you are telling them. So it is kind of this. So use compelling stories of the vaccine preventable disease. Like one of the thing that they thought that it might be causing some genital anomalies, or maybe some Down syndrome or something like that, or maybe autism. So you have to know how you are going to address all those things. So communicate clearly to address the disease risk and vaccine. So you have to tell, in Canada we don't use these kind of vaccinations which will cause any harmful effects on the babies or any on the children's. So we are using the safe ones, and we haven't encountered any situation up till now. Thousand of the babies has already gotten vaccination and nobody got this problem so far and stuff like that. Address immunization pain. If somebody is saying that my baby will have a pain or those things, so you can tell them there is Tylenol we can give, and on the same time we can keep on check the baby. If he's having any other problems, we'll keep checking that and treat it according to that. Wait and see approach to the immunization is an outbreak scenario and everything. So parents who refuse, so you have to ask, other than the baby, or those parents are immunization or not, like have they been vaccinated or not. Protection of the child from the occurring illness, so you have to tell everything. This is so non-vaccinating risk of the health, weakened immune system. Then comes the immune health the professionals of the lack of vaccination, which when child is sick, if a vaccine preventable disease is in your community, get vaccine, may be prevented to stay away from the school. So in pertussis, particularly in what else. So there are many, like in pertussis, in pneumococcal, in those kind of influenza, HIV, influenza. So, and those are those particular chicken pox, measles, rubella, those kind of things which are spreading from one person to another person. So you have to ask the baby or particular patient to stay home until that disease is resolved. So you need to know how many days that patient need to stay home for which particular disease. Like in pertussis, they have to stay for 5 days. In measles, they have to stay for 7 days. So you have to remember each and every time period for all of the diseases. Tetanus does not have in community protection. So for that, travel vaccination to geographic refuse permission to travel. So if they're going to some particular place where there's some endemic going on, so if they doesn't want that vaccination, you are obliged to tell them that they are not supposed to go there. Then comes the milestone. Okay, so this one, motor reflex, gland reflex, grasp reflex. So you can read them, what and how those reflexes are performed. But the main important thing is age of disappearance. So when are they going to present and when are they going to disappear? So most of the reflexes disappear by the age of 6 months. After 6 months, if they're still persistent, so here it is written, a persistent after 4 to 6 months is basically cerebral palsy. Primitive reflexes are abnormal if absent using neonatal periods, asymmetrical and persistent after 4 to 6 months. So all of these reflexes should be disappear by 6 months. I mean, there are gland and grasp, they should be disappeared by 3 or 4, but the roughly age is 6 months. So it should be like disappeared by the 6 months. If they still persist, it means the baby is having a cerebral palsy. Other than that, if the baby is having tendon reflex response is asymmetrical, suggest focal motor lesions, and absence of the hyperreflexia may suggest of CNS abnormalities. Upgoing plantar reflex is like Babinski, normal up to 2 years. So this is kind of different, okay? Every reflexes should be disappeared by 6 months, but which one is not going? Babinski. It should be stayed up to 2 years. Now come this part. This is kind of a tricky part. How I remember, I will tell you, so you guys can remember in that way if you like. So this is just my way of remembering it. So you can remember it however you like. So newborn baby is basically what kind of reflexes? All those Moro, Babinski, and everything is present. So he has a grasp and speech and language. Obviously, he's just only gonna suck. Cries, and cognitive is basically he's not gonna do anything particularly, like social bonding between. Then comes the 2 month. Now 2 month baby is basically a baby who can. So 2 month is basically February. February is basically important for like when like how I remember is basically February. In February there is Valentine's Day, right? So in Valentine's Day, what happened is basically social smiles start developing in Valentine's Day, right? So baby start picking up his head. So in the Valentine Day, they start developing feelings and stuff like that. So I have remembered it like in 45, they start picking up their head and start developing social smile. So social smile is important in 2 months. Then comes the 4 month. What happened in 4 months? January, February, March, April. So in come April. April is basically like April Fool, right? So in that, what happened is squeals, laughs, patient, they explore their parents' faces, right? So they can explore their parents' faces and then starts laughing and prones to like supine to prone, so they are able to move around, right? Then comes the 6 month. In the 6 month, it comes like June, July, right? So what happened is basically baby starts sitting. So you can take the baby to the into the park, and what happened over there is they might start expressing their emotions. They see stranger and start like crying and everything, right? So stranger anxiety develops in 6 months, right? And they start babble, start making some noises. If you take them outside, like remember if the 6 month is like a, because I'm remembering it with the temperature of the Canada. So 6 months is like a kind of nice temperature. So everyone go outside. So you can take the baby to the park. And what happened over there is basically they start developing this babble, strange anxiety, starts showing their emotions, happy, sad, and mad. Then comes the 9 month. What happened in the 9 month is basically November. Sits well without sports. So basically crawls. In 9 months in November, what happened is school starts, right? So baby doesn't want to go to school. It's just a way, right? It's not applied to anywhere, but it's just a way. Like a baby doesn't want to go to school. That's why it start crawling. So it pulls to stand, right? So inferior, and then they start saying mama, dada, because they don't want to go to school. And then they have this separation anxiety because they don't want to go to school. So this thing is applied. And that's how I remember. At the same time, you guys can remember however you want. Then comes the 12 month. What happened is obviously 1-year-old baby. What will they start doing is taking few steps, speaking one word. Everything comes one, one, one. One step, few pine pincer, one word, uses objects, and wherever they are They want the subject. So one is basically pointing. So that one finger is pointing towards the wanted objects. 1 year, one word, one step, and points at the wanted object. Then comes the 6 15 months without sports. Sorry, walks without sports, crawls to the stairs and stacks up to 2 blocks. So they start like blocking up. And then obviously their words is going to increase by 4 to 5 and one body part. Look at for the moved hidden object if saw if being moved, then basically shared attention. 18 month is very important because at this particular point you are going to make the decision that his milestone is disappearing, appearing, or lagging behind in these kind of stuff. So what happened here is if the baby is not even standing up when he was supposed to run and stood and recovers, right? But he's not even standing up or he's not even taking one step. So this is a problem here, right? He's supposed to make towers for 4 blocks. Now he's not even doing a pincer grab. So this is a problem. He's supposed to make 15 to 25 words. He's not even speaking one word. So this is a problem. Symbolic, he's supposed to speak like at least body parts and, parallel play that when there is an infatuation that there is another person present, he's talking to that person. But now at least he couldn't even make that one word or he couldn't show any emotions. So now there is a problem. So 18 month is very important. You are going to make the diagnosis of that this is having a lagging behind milestone problem or these things. So at least remember 18 month. Then comes the 24 months. So you can remember at 24 months, 2 years, 2 feet, 2 to 3 word phrases. Everything comes in 2 to 2. So tower of the 6 blocks, new problem solving questions and testing limits. So in comes the 3 year. 3 year, what happened is 3 3 3 3 3. Everything comes in 3. He's going to start riding tricycle, 3-step command. Is going to count to 3, cooperative play and roll. So everything comes in 3 3 3 3. Okay, and separates easily, sharing. So now this 3-year-old baby start going to the different person. So he's okay with it. Then comes, and because he's going to start recognizing the person around them. So he knows this is my brother, this is my sister, and everything. 4 is basically he's going to start hopping. Use scissors, speech, and identifies at least 4 colors, has a preferred friend. 5 years skips and prints name, ties, shoelaces, and fluent in speech and counts up to 10 accuracy and has group of friends. Now this is important. What are the red flags? Everything, every disease, whatever you are studying, make sure you know the red flags. What are the red flags? Basically, like something which is basically you cannot ignore in that particular disease, in that particular scenario, right? So now come in the red flags is basically what happens in the gross motor, not walking up to 18 months. So after 18 months, you start making the diagnosis. Yes, this is lagging behind. This is not a problem which we cannot, which we have to look into. Not walking at 18 months, rolling too early at less than 3 months, fine words, hand preference at less than 18 months. Speech is basically less than 6 words at 18 months. So there is a difference between uworld and in Canadian. In Canadian, it's less than 6 words, but in uworld, it's written less than 10 words. So make sure you know the Canadian one. Social smile, not smiling at 4 months, not pointing to 15 to 18 month. And then comes a speech that checklist is present. And then regression is basically loss of previously acquired skill is a red flag at any age. Let's suppose a baby is coming at 9 months and he was able to do tripod sitting. Now he cannot even sit straight, right? He could not even roll, right? So this is a regression. So this is a problem at any stage. If there is a regression of any acquired skill, so this is a problem. This is the red flag. Then comes the next one. Next is basically crying child. This one is important too. You need to know the breast milk and which one is given at which time. Okay, the indications. So make sure you know these kind of, when you are going to give which kind of milk to what kind of particular disease. So in galactosemia, you give soya milk. So in prematurity, you give cow milk. So this is important. And then this is signs of inadequate and signs of adequate intake. So you need to know when the baby is dehydrated and when the baby is properly hydrated, and you are not giving too much fluid to the baby. Okay. So this is important as well. Injury prevention counseling. What are you going to tell at the particular patient? So let's suppose a baby is coming to you at the 6th month, right? And their parents are asking you, what should we take care of? How we should take care of our baby, because this is our first baby. So we want you to tell. So you need to know what at 6 months, what particular things you should tell the parents to take care of, so they can handle the baby properly. At 1 to 2 years, they are coming. What are you going to tell? 2 to 5 years, what are you going to tell? So this is important as well. Then common complaints, breath holding, spats, and crying. So I'm going to read both of them because they are kind of linked together with each other. So breath holding spells comes in two types. Which one is the more common? Cyanotic, and then the other one is pallid. Pallid is basically anemic, like it looks like the patient is anemic. It went like he's having too much, like he went yellow, he turned yellow. Now the cyanotic is basically the baby turned because of anger, frustration, he turned blue. Now the pallid is basically he turned yellow because of the pain and surprise. Suddenly somebody try to surprise him, and he got so shocked that he turned like into that particular stage. So what happens is the etiology is basically provoke child due to anger, injury, or fear, hold breath, and become silent and spontaneously resolve or loses consciousness. So what are more the more common, the more it's gonna be like, the scenario is gonna come from the more common one. So management is basically usually resolved spontaneously. All you have to do is reassurance the parents, and median age of the remission is basically 4 years, and all children should usually stop by 8 years. So what are we going to do is help child's control response to frustration and avoid drawing attention to spell. Maybe associated with iron deficiency anemia. As I told you, pallid is basically like looks like anemic, but you still have to rule out maybe it's iron deficiency anemia. So improves with the supplemental iron. So you have to look behind, maybe something is underlying pathology. So just to rule out iron deficiency anemia, so he needs an iron, you give iron, condition is resolved. If the symptoms prolong, so you need to rule out maybe there is PTSD going on, something psychologically thing is going on. If there is a family history of any syncope or any heart disease, so you have to rule out the prolonged QT interval. This is also very common. So then comes is a crying or the fussing child. So common etiology is basically functional. Most of the child is crying because of he's hungry, his diaper is wet. So you have to rule out the basic things before going starting any CBC or anything like that. So you need to know that either the parents are taking care of the baby properly or not. If the baby is not being taken care of properly, you are going to do CBC and blah blah blah. Everything is basically, let's suppose you start the medication and everything is done, still the baby is crying, right? So you have to start from the baseline. Description of the baseline is basically feeding, sleeping, and crying patterns. Infections like fever, tachypnea, rhinorrhea, in context, GERD, esophagitis, and so everything you have to ask in the history. Then is inconsistent history, maybe patterns of the emergency department visits and social living conditions can raise concerns for the maltreatment, and broad array of possible underlying causes such as meningitis, sepsis, might be anything underlying going on. But make sure you first rule out the common ones. So don't forget common ones just because you are ruling out uncommon ones. Okay. Infantile colic is basically clinical features, unexplained paroxysms of irritability and crying for more than 3 hours per day, more than 3 days per week, or more than 3 weeks. So everything 3, 3, 3. Rule of 3 is basically vessel criteria. So unknown etiology is basically unknown, but something is hidden. And which is that one? Smoking, and maybe cow milk intolerance and GI immaturity, but you cannot miss out smoking. A diagnosis of exclusion is basically history and physical exam to rule out any identifiable causes such as otitis media, cow milk intolerance, GI problems, and fractures. What are you going to do is first you have to help the parents to counsel them to their mental health, because the baby is crying so much, so they are frustrated, they are in anxiety, they are in panic attacks. So you have to give them reassurance and relief and rest before telling anything else, right? So first thing first, where you have to start with the parental relief, rest. When the parents are calm, now they can do the baby, even take care of the baby properly. Change breastfeeding, maybe bottle technique is the problem, maybe the hold baby soother, and you can counsel about that. If the baby's throwing fits, what are you going to do is, there is a scenario in of that in MCC. I would maybe you guys can go and check it from there, but I will also try to post it in the group, so you try to solve it. Probiotics and research required breastfeeding and eliminate allergens like protein, eggs, wheat, and nuts from the mother's diet. All resolve most in the first 3 to 6 months of the life. No life long term adverse effects. Then dietitian and carries, you can see it is basically started in 1 year. So you have to take the baby to the 1 year. Involve dental health clinic by the age of 1 year. Then is enuresis. Enuresis one is the very, very commonest. So you need to know at least the primary and the secondary. Then there is basically nocturnal in the daytime and those things. So at least you need to know the primary and secondary one. And what happens is basically enuresis is basically involuntary urinary incontinence by the day or the night in the child more than 5 years. So if this is coming in less than 5 years, what happened? This is totally normal because child, he start developing enuresis by the age of after like 4 or 5 years. So it is totally normal if they're coming like before 5 years, right? So you have to just counsel them, it's totally fine and everything. But after 5 years, if you are coming, you have to rule out is it primary or is it secondary. So general approach is basically rule out any dysuria, maybe any UTI going on, any post-streptococcal glomerulonephritis going on. So you have to do change, order, stream, secondary or diurnal. Maybe the problem is something else, change in the gait, stool incontinence, maybe any back problem, any cauda equina. So you have to rule out everything. So this is basically general approach. And general approach is basically asking in the history all those questions to rule out as many as diseases you can. Treatment of the primary nocturnal enuresis should not be considered until 7 years due to the high rate of spontaneous cure. So I'm talking about primary here. We will talk about secondary, but you need to know the primary. Primary comes treatment after 7 years. What is primary? Primary is basically when the bladder has control has never been attained. So the baby has never attained any bladder control, and now he has passed 5 years, and now their parents are coming and they're concerned. Oh, my other baby started, and bladder control at the age of 4, and this is 6 year, and he couldn't even, control it. So now they are coming. So all you're going to do is nothing. We're going to see here develop disorders of maturation of lag and this etiology like while asleep. Then management is basically time reassurance because baby is still like in progressing age, so you cannot start the treatment before 7 years. So what are you going to do is treat time reassurance, avoid of punishment or humiliation, behavioral modification like limiting fluids, maybe baby is taking too much fluid, juices, all those caffeine products before going to the bedtime. It's easy for the baby to reach to the toilet, take out diapers, and conditioning like wet alarm child upon voiding like 70% success rate. So wet alarm and medications, if you have to choose from both, I will go with the wet alarm. Then after choosing wet alarm, if he still couldn't do it, then go for the medication. Let's suppose he wants to go to some picnic, some party or somewhere, but he wants the treatment right away, right, within like 2 to 3 days. So what are you going to do is basically medication, but that medication should be started after 7 years. It is very, very important that I keep on highlighting the 7 years. So you need to know this. This is the age where we are going to start the medications, and this medication is basically second line. Okay, so you're not going to start with the medications. So you have to start with the wet alarm and then comes the medication. What are the medications? Desmopressin and imipramine. Let's suppose I have to choose between desmopressin and imipramine. So what I'm going to choose is desmopressin because it has less side effect and more successful rate. Okay, because imipramine has like a lethal of overdose, so baby might can take more than what is needed. So it can cause cardiac toxicity and anticholinergic effect. Then comes the secondary enuresis. Clinical features: enuresis develop after the child has sustained period of the bladder control more than 6 months. What happens is inorganic regression. Now secondary, baby has already developed. Now he is having this bladder uncontrollable thing going on. So it is important you know what is secondary and what is primary. Primary is basically when he couldn't even started it from the first place. Secondary, he already started it, but now what he's doing is basically he cannot control it for at least more than 6 months. So if it's coming for 1 to 2 months, it's totally fine. Maybe he's having some problem and then he could totally resolve it. But it's more than 6 months and he couldn't do it. So now it's the problem. Maybe some UTI, some diabetes mellitus, some diabetes insipidus. So you cannot just miss it and let the patient go, right? So inorganic regression started. Maybe he had already controlled it and now he couldn't control it. So this is basically a regression, right? So now secondary to organic causes may be UTI, diabetes mellitus, diabetes insipidus, sleep apnea, neurogenic bladder, CP, sears, pinworms, all of these are. Management is basically you have to find out the proper cause because I already told you it is something underlying pathology going on. So you have to rule out that cause and treat that cause instead of doing reassurance, right? So now there is a difference. Primary, you start with the reassurance. In secondary, you cannot go, oh, it's okay, you can come next time, maybe he's totally fine. No, you cannot do that. This is kind of dangerous if you do that. So this is you need to know on the basis of the presentation, you need to know which is primary and which is secondary. So on the basis of that, you can decide the management, treat underlying cause and specialist referral as appropriate, maybe having diabetes insipidus. So now you need to know which is central or is it nephrogenic. So you have to rule out and then start the diagnosis. Then comes the diurnal enuresis. Now this is something which is totally different from the enuresis. Now those ones were nocturnal, right? Having the problem at night. Now diurnal is basically having the problem at daytime. Okay, so now if they are giving you a scenario about diurnal, they are going to specifically mention the baby is having a problem at daytime as well. Like 6 to 80% also wet at night, but daytime is important. What happened is viturational deferral, like holding urine. Maybe baby is holding urine until the very last minute due to psychological factor. Baby is shy, baby is traumatic, baby is having some depression, any etiology going on. So if somebody is giving me this diurnal enuresis and asking me what I'm going to rule out first, so I am going to rule out any psychological stressor. Even in the same time, I'm going to rule out in the primary nocturnal enuresis. What are you going to rule out first? Is any psychological problem. In secondary, mostly it's any clinical problem, but still you have to rule out psychological first. Psychological first comes first because on that you don't have to start any medication, you don't have to do any test. You find out on the basis of the history and treat it on the basis of the history, and all you need to do is counseling. It will get well. Baby needs to be some good words, and he will definitely get better with that. Structural anomalies may be ectopic, urethral site, neurogenic bladder, UTI, constipation, CNS disorders, diabetes mellitus. Management is basically treat underlying cause, behavior, all these things, which I already told you, psychological stressors. So this is what are you going to do is behavior like schools toileting, double voiding, good bowel program, sitting backward on the toilet, and intensive relaxation. Whatever the problem is, you have to address it and help him to get over that problem. Then if that thing is not working, maybe he's having underlying constipation problems, so you have to treat the constipation. Now all of these things you have done, and they have mentioned in the scenario that you have tried so far everything. Now what you can do is start with the pharmacotherapy, but still you need to look up the baby's age. Always when you are solving any question, make sure you look the age, make sure you look how much he is having this problem, for how long he's having problem, how is it affecting the person, what kind of the presentation is coming, what was the past history, what is the setting, is it coming in the clinic or is it coming in the emergency. So on the basis of all of this, the management, the investigations, everything changes. So you need to know what is the everything. These all particular points that I mentioned, you need to know one by one everything, and you applied, okay, yeah, this is it, this is it, this is it. So on the basis of that, you will be able to choose it. Try applying these things on your questions and try solving it. Then comes is basically failure to thrive. I think that is very long topic and we don't have enough time. So then let's see. Then comes the mid-parental height. Mid-parental height is basically boys' target weight, height. How are you going to do is mother plus father plus 13 divided by 2. Then comes is girls, mother plus father, but minus 13 divided by 2. So you can remember this formula. Then clinical signs, small kid, subcutaneous fat, muscle trophy. So all the features are written here, but if you can remember this one, this is good enough. But if you can remember this one, this is even more good. So you can remember the clinical features, all the history, nutrition problem, current intake, illness, growth, puberty, physical exam. In the physical exam, what you are going to find, maybe in the less than 2, you have to, this is the thing. Less than 2, what are you going to do? Check is head circumference. But in more than 2, what are you going to check is basically BMI, okay? Vital signs, head to toe. So in the physical history, you need to know what are you going to check. So because in the physical history, this is basically non-invasive. So first comes non-invasive, then comes invasive investigation. So starting from the physical exam, all of these vital signs, head to toe, dysmorphic, ratios, sexual maturity, signs of the maltreatment, then investigations. What are the investigations? CBC, blood smear, electrolytes, T4, all the thyroids, because thyroid can present with a small baby, and then urea, ferritin, calcium, celiac disease, vitamin A, D, E, and bone age, karyotyping, chest X-ray, cardiac disease, because you want to rule out celiac disease, any underlying pathology going on, maybe any congenital problem going on, celiac, inflammatory, Wilson disease, any renal urine analysis, and liver and enzyme. Then here, upper to lower segment ratio. What happens if it's increased? What is the diseases when it's decreased? So if it's increased, is basically achondroplasia. So if you can remember these ones, it will help you a lot in solving a lot of questions. If you just could remember this one. But if you want to make any concept, yeah, go for it. But it's going to take a little while. So just, if you can remember, upper to lower is basically achondroplasia, hypothyroidism, and storage. But if it's decrease is basically when there is a Marfan syndrome, Klinefelter, because there is only one particular part is bigger than the other one, or maybe the whole body is bigger than the other one. So on the basis of that, you can tell, yeah, this is achondroplasia because one part is bigger than the other one, right? But Marfan syndrome, the whole body is affected. Klinefelter, the whole body is affected. Kalman, the whole body. So all those congenital anomalies comes with the decreased one, but in increase, or like all these achondroplasia, short limbs, so different ones. Okay, so these you can, I guess, remember in that way. Then failure to thrive is basically if this is just the weight is decreased, it means the baby is not taking enough proper diet or increased losses. If this is both weight and height is decreased, then constitutional growth delay and familial. So this is important. You need to know bone age is less than constitutional age. If this is normal, then it's basically familial, something family history is going on. So you need to remember this one. This one is important. Decrease, both of them are decreased, is basically the baby is born in like that way, genetic abnormality is going on, so everything is decreased, so something underlying pathology. Then comes etiology and management. Management is basically, etiology is basically all those, those diseases, everything is mentioned in like collectively. Then management is basically multidisciplinary approach, because you have to see what is the problem going on. Maybe a physician is needed, occupational therapist is needed, dietitian is needed, psychologist is needed, social workers is needed, and maybe the baby is having any social trauma, any child abuse is going on, so you have to contact the CAS. Then on the basis of that, you have to rule out any oromotor, maybe cleft palate, cleft lip, so you have to rule out iron deficiency anemia, give iron. GERD is going on, so you have to start with PPI. So you have to rule out, maybe medical physician is needed, maybe diet is problem, maybe CAS is needed. So it is a multidisciplinary approach. Then nutrition is educate about what the food is. Maybe the parents are not giving food, but they are not making the formula properly, so you have to educate about them. Then comes the environmental growth to 90 to 110%, and nutritional deficiencies and promote catch up growth. And behavior is basically positive reinforcement, mealtime involvement, and no distraction. Like maybe they are getting distracted, so you have to tell them about the distractions and during mealtime. So I will stop here, and from tomorrow I'll first do those topics which we couldn't do today, and from there on we will continue from the rest of the topics. If you guys have any question, feel free to ask me.